All right, so regulating prescription drugs, done in a much different way than regulating alcohol and regulating illicit drugs. So, in general, the modern way to regulate prescription drugs and psychopharmaceuticals, which we've been focusing on in this class, is through what's kind of termed the prescription drug triangle. So, you have three parties involved: you have the physician, the pharmacist, and the patient. The physician actually writes the prescription for the drug of choice. So, they treat the patient, or they examine the patient, they diagnose the patient, and they figure out what medicine is most appropriate for that patient to take. The physician writes the script, writes the prescription, and hands it over to a pharmacist. The pharmacist is the one who actually dispenses the medication to the patient, which the patient then consumes. So you have these three parties all coming together. Now, I say that this is a modern way to regulate prescription drugs by separating out the role of the prescriber and the dispenser, because that's not how it's always been done. It's only been done for maybe the last 110 years, in all honesty. And there's still countries out there where the physicians can both diagnose and dispense, and countries where the pharmacists can both diagnose and dispense medications to the patients themselves. Now, it does get a little bit more complicated than just saying that the physician, the pharmacist, and the patient, they're the only ones involved, because there are other entities involved in this process. So each parts of these triangles, each side of this triangle, has these advocacy groups, these trade associations behind them, advocating for the rights and responsibilities of their position. So physicians have multiple physician trade associations. You have the American Medical Association. I think every specialty has their own association. Pharmacists have their own associations, and what they'll do is they want to advocate for the most expansive abilities of their profession, as well as the highest wages of their profession, and those go hand in hand. The more a physician can do, the more that they're going to get paid. The more pharmacists can do, the more pharmacists is going to get paid. And then you have patient advocacy groups that are focusing just on the patient. What is the best thing for the patient? A physician may want to diagnose and dispense medication at the same time, but for the patient themselves, that may not be the best thing because there's a conflict of interest there. If a physician or a pharmacist can both diagnose disease as well as dispense medication for disease, it's certainly better for them to diagnose more things even if they're not there. Now, there's two things that link these three sides together. One is government regulation. Now, there's not too much regulation on the patient, or regulations are for the patient's benefit, ideally. But physicians are highly regulated by the government, both at the federal level and at the state level here in the United States. Pharmacists are regulated at the government level and at the state level, both in terms of what their jobs are, what they can do, as well as what they can dispense and how they can treat. So they're kind of bound by those regulations. But then you also have these outside, other, like external influences coming from the manufacturers of pharmaceuticals, the distributors of pharmaceuticals, as well as those who want to promote pharmaceuticals. So even within this relatively simple prescription drug triangle, you have these multiple layers of people and organizations trying to influence what people can do and what they can't do. Again, in general, physicians and pharmacists, they're going to advocate to be able to do more. So to do more diagnoses and do more dispensing of medications. Patients will act more for themselves to protect the patients because they don't want to be taking something unnecessarily and expose themselves to excess risk. You have government regulations who are kind of controlling this whole thing, but restricting what physicians can do, restricting what pharmacists can do, and hopefully protecting the patient, because that should be what's most important in these regulations. But then you have these outside entities of the triangle, and these are the actual manufacturers and the actual distributors of pharmaceutical medications, who essentially want as much of their product on the market as possible. Now, there are other ways outside of this triangle, outside of doctors prescribing, pharmacists dispensing, to control the use of prescription drugs. So there's other prescription drug control policies out there. Some of them include pharmacist counseling. So actually counseling pharmacists themselves, or having pharmacists offering counseling to others. You can actually change the reimbursement rates for certain medications, where for instance, there'll be a separate video on opioids, but for instance, if we want to really encourage doctors not to prescribe opioids anymore, or we want to encourage pharmacists not to actually dispense opioids anymore, maybe we lower the reimbursement that health insurance companies or patients themselves out of pocket would pay for opioid medication, but we increase the reimbursement for non-opioid pain medications. Now, the patients may not see this because of prescription drug coverage and health insurance, but this could affect the bottom line for those physicians and those pharmacists. And then providing guidelines and education. So actually informing people about bad things that are happening with certain pharmaceuticals, informing them about good things that are happening with others, and then setting guidelines, kind of like best practice standards for the industry, both for physicians and for the pharmacists. Now, these do work, amazingly enough, guidelines and education do work in the prescription drug control world, but it has to be new information about a new drug. Typically, it has to be about an adverse event, so it's easier for people to react negatively to something. For example, Vioxx was pulled from the market because it was, killing people. And it has to be delivered by peers that they recognize and respect. So fellow pharmacists or fellow physicians need to actually deliver this information. We do have over-the-counter medications. Like, it's relatively easy here in the U.S. to go to a CVS or a Walgreens or any pharmacy and buy, or grocery store or Walmart or Target, any of them, to buy OTC medications. You can buy Tylenol and aspirin and allergy medications and cold medications and many, many others. They're available without a prescription. They're relatively easy to obtain. Here in the U.S., for a prescription medication to get over-the-counter status, it has to prove that it's safe and effective, like without a physician's supervision, without pharmacy oversight. The odd thing about this, now you're making it really easy to obtain, but there's kind of two strange consequences of allowing medications to be sold over the counter. One is that they are actually likely to be more expensive. We might actually be paying more out of pocket because they're not covered by health insurance plans anymore. So instead of paying a $5 or $10 copay, maybe we have to pay $15, $20, $30 for the full price of those medications. And they actually may be viewed as less effective. So on a very basic example, right? Like, I always try to bring it down to, like, what is the most obvious example? Let's say someone buys ibuprofen for pain over the counter. Even at the same dose, that may be viewed as less effective than a prescription for ibuprofen obtained from a physician and dispensed by a pharmacist. And finally, if we're going to talk about prescription drug policies, I do have to reference the marketing of prescription drugs. Most of the marketing is directed towards doctors themselves. They do this by sponsoring things such as continuing education credits, conferences and other professional development activities. During these events, they'll provide things like free food. So a pharmacy rep can't take you out for a steak dinner anymore, but if they have a conference and it's a continuing education event, they can certainly supply you with food and drink to whatever they would like to pay for it. And then small gifts. So amazingly enough, a single pen is enough of a gift to change someone's pharmaceutical practice, or prescribing habits, excuse me. And small gifts aren't just pens and pads of paper. They'll actually get free samples as well. And then those doctors will pass along their free samples to their patients, oftentimes going around the pharmacy system entirely. Now, New Zealand and the US do allow direct-to-consumer advertising. So people, just ordinary lay people, can be advertised directly by these pharmaceutical companies. And this is just as effective. Both of these tactics significantly impact prescribing behavior. They increase the number of prescriptions and they increase the type of prescriptions. So more prescriptions will be written and dispensed for the products that are advertised the most.